Good morning, everyone. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Effective Treatment for Individuals Experiencing Homelessness and Behavioral Health Issues. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Before we get started, let's go over a couple of technical details. Please note that as an attendee, you are in listen-only mode and will only be able to view your own name. If you have questions, please send them to the presenter and me, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them, and the presenter will address the questions. Also, you may find it helpful to open up your chat panel. I will be posting technical and administrative information to all attendees through the chat panel, and you may find that helpful. Our audio is being broadcast through the internet to your computer. You must have speakers attached to your computer and have the correct software and the volume on. If you do experience poor computer audio, there are a few options to try on screen right now, and these options are also posted in the chat panel. If you continue to experience a loss of audio through your computer speakers, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FATA website within 5 business days. Also, a PDF version of this PowerPoint presentation will be emailed to participants also within 5 business days. Approximately 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and also for persons credentialed through the Florida Certification Board. At the event's conclusion, the web browser will direct participants to an evaluation form on the FATA website. If you would like to receive continuing education credits or a certificate of attendance for this event, you must complete the evaluation. Be sure to include any Florida license number as applicable for reporting to CE Broker, along with the prefix for your license number. Note, too, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. This attendance log and the evaluation forms are used to validate the provision of contact hours or the certificates of attendance. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar, and we're not permitted to provide partial credit. At this time, I'd like to go ahead and introduce our presenters for today's webinar. Susan Pourciau, PhD, is the Director of the Ending Homelessness Team for the Florida Housing Coalition and serves as the organization's Chief Financial Officer. The Florida Housing Coalition is a statewide nonprofit organization that provides training and consulting services for communities throughout Florida as they work to end homelessness and increase access to quality, affordable housing. Her areas of expertise include housing first, rapid rehousing, systems design, performance measurement, organizational change, and data-driven decision-making. Prior to joining the Florida Housing Coalition, Dr. Pourciau was the executive director of several human services nonprofit organizations and was on the faculty of Florida State University. She has a doctorate in accounting and a law degree from Duke University. Amanda Rosada, MSW, is a technical advisor with the Florida Housing Coalition. For the past 10 years, Ms. Rosado has worked with individuals and families experiencing chronic homelessness in various settings, including a drop-in center, emergency shelter, HIV clinic, and permanent supportive housing programs. In 2010, she assisted in piloting Columbia, South Carolina's first Housing First program for chronically homeless individuals, families, and persons living with HIV/AIDS. Prior to joining the Florida Housing Coalition, Ms. Rosado worked with a behavioral health managing entity in Northeast Florida. In that role, she worked to provide housing as an effective healthcare intervention for consumers within the substance abuse and mental health system. As a strong advocate for Housing First and recovery-oriented systems of care, she is passionate about utilizing evidence-based practices and providing effective interventions to work with some of the most vulnerable populations. She earned a master's degree in social work with a focus on organizations and communities from the University of South Carolina, and we're very pleased to have both Dr. Pourciau and Ms. Rosada joining us today. And first, Susan, if you're ready, I thought I'd go ahead and turn the control of the presentation over to you if you're ready.
That sounds great, Leanne. Thank you.
And I'll go ahead and bring up the presentation for you as well.
All right, good afternoon, or good morning, everyone. It's so wonderful to be here today. I'm Susan, and I will be starting off the presentation and then handing off to Amanda later in the day. And I'm so glad that you're here, and we appreciate the support of FATA and DCF to make this webinar available. We will be talking about persons experiencing homelessness with a special emphasis on those with behavioral health disorders. I need to go back to the learning objectives. The learning objectives for today's webinar are as follows. We will talk about using a strength-based, client-centered approach to case management for these individuals with behavioral health problems who might be homeless. We'll talk about evidence-based practices and give examples of how to work with those evidence-based practices. We will learn how specific examples of effective and innovative ways to assist folks who are homeless to obtain and remain in stable housing, and learn how to facilitate housing placement and recovery by working more closely with collaborating entities, housing programs, and organizations. This is an overview of our PowerPoint presentation for today. First, we'll be discussing the characteristics of households who are homeless. We will discuss the Housing First approach, effective case management approaches, and the Housing Crisis Response System and collaboration. So first, let's turn to characteristics of households experiencing homelessness. First of all, let's talk about some of the misconceptions related to homelessness. You'll see on this slide some of the common misconceptions about people who become homeless. They are often identified with very specific kind of individual characteristics or problems. And homelessness is often attributed to these negative factors and these individual characteristics. Even in the professional field of behavioral health and among those who work in homeless shelters and similar environments, these misconceptions persist. They often lead us to engage in interventions that are not the best solution. If we hang on to these misconceptions, we actually may be slowing down the process of recovery for the consumers with whom we work. So part of what we need to look at is our own misconceptions about people who are homeless. And we need to recognize that the majority of people living with issues such as mental illness, substance use disorders, and similar factors are, in fact, in housing. They are not homeless. There's more than 1.2 million Floridians who are estimated to have a serious persistent mental illness, and fewer than 0.5% of those are actually experiencing homelessness at any point in time. So clearly, substance abuse and substance use disorders and mental health problems don't cause homelessness, but they are present among those who are homeless, just as they are present among those who are housed. And so the truth of the matter is that the one common issue that people who are homeless have is that they don't have housing that they can afford. The mismatch between income, household income, and the cost of housing and maintaining housing is the one primary factor that causes homelessness. And so in finding solutions to homelessness, housing really is a factor. We know from data and research that there are almost 1 million Florida households that pay more than 50% of their income for their housing. So that puts many Floridians at risk of homelessness. And those who have been evicted or have become homeless or particularly those who've been homeless a long time have a lot of difficulty moving back into housing and maintaining that housing given the mismatch between their potential income and the housing costs. And when we look at the numbers of people who are homeless, these are the point-in-time count numbers. So this is just a one-day snapshot of people who are homeless in Florida as identified by the annual point-in-time count in 2017. There were about 32,000 people identified as literally homeless. That is, people in shelters, encampments, transitional housing programs. Of those, about 13% were identified as having substance use disorder, and about 15% were identified as having severe mental illness. So what we're talking about here are a minority of those who are homeless, but often, as all of you know, those consumers that really need a lot of help and support as they move back into housing and into recovery. We're going to turn now to talk about Housing First, and in Leanne's introduction of both Amanda and myself, you heard her mention Housing First a couple of times. So it's good to make sure we're all on the same page about what we mean by Housing First and how that will help us move forward. First of all, the idea of Housing First is an evidence-based practice that was born out of the substance abuse and mental health field. So it was first tested and validated with consumers that had behavioral health issues. the idea of Housing First has been broadened and recognized as an appropriate approach for all folks who are homeless, regardless of whether or not they have behavioral health issues. And I think it's instructive to recognize that the idea of Housing First actually came from the behavioral health field. So what is Housing First? The idea or the philosophy of Housing First and having a housing-focused system is that what we really want at the end of the day is for homelessness to be rare, that is, few people experiencing homelessness. But if they become homeless, we want that episode of homelessness to be brief as possible. We want to help people get rehoused as quickly as possible. And finally, we want homelessness to be non-recurring. In other words, we want to help people remain stably housed once they are housed. So one of the things about the Housing First philosophy to note is that it's not housing only. This is a misconception about Housing First, the idea that, well, you just give someone an apartment and then walk away and wish them well. It's Housing First, but not housing only. So Housing First, services second is the implied and probably should be explicit. Housing First, services second. So housing is seen as the platform for recovery that is so important for those who have behavioral health issues. They are much more likely, and this is proven with data and evidence, folks with behavioral health issues who are homeless are much more likely to engage in recovery activities and actually enter inpatient or outpatient treatment, become stably housed, become employed, if they are first helped to obtain housing, rather than the flip side. Providing services to folks who are still experiencing homelessness but not housed makes that recovery process quite difficult. So as you can see, the idea of Housing First is really a key idea for folks who are working like you, who are working with people who are homeless and have behavioral health issues. There is an entity called the United States Interagency Council on Homelessness that aggregates best practices and helps to facilitate the federal strategic plan to end homelessness. They work with HUD, HHS, Department of Corrections, and Department of Employment, many other agencies at the federal level. And the USICH have recognized, the council of all of these federal agencies recognize that Housing First is important and primary solution. And the way they define Housing First is that the approach guarantees that there are few programmatic prerequisites. In other words, in order to for a person who is experiencing homelessness to get engaged in the system, they should not first be required to do X, Y, and Z, where X, Y, and Z might be enter inpatient treatment first, or become employed first, or be compliant with mental health treatment. So what we want to do is reduce those prerequisites and reduce the admission policies to Housing First type programs. We also want to engage folks immediately into the system that will help them be rehoused into permanent housing. So not shelter or transitional housing, but actual housing like an apartment. We want folks to be able to engage in support services as they are ready, and we want to focus on housing stability once folks are housed. And a large part of that, of course, is ensuring the access to treatment and support services. So the Housing First approach isn't just a program or a project, it's a whole system orientation. And it changes the way a community and all of the providers within that community respond to homelessness. Now, I am going to turn the presentation over to my colleague, Amanda.
Thanks, Susan. All right, so now we are going to discuss some effective approaches you can use in your role to help your clients experiencing homelessness. And even though I have written here case management approaches, this actually applies to anyone working in the behavioral health field. So if you're a clinician, or even if you're, frontline worker, this applies to you. So these 4 things here are what I consider the must-haves for case management in general. These are like the values that you should have in this line of work, and they're very important, especially when working with households experiencing homelessness. So really, any staff and organization serving these households need to be trauma-informed, need to be recovery-oriented, strengths-based, and client-centered. All right, so let's define these. All these approaches are available in more detail, and I encourage you to seek more training on each of these areas, especially like trauma-informed approaches. You can find so many materials online for this, so we have a limited amount of time to talk about each of these, so I really encourage you to explore the resources more. So the reason a trauma-informed approach is so important when working with our clients really is the staggering statistics and trauma histories people are walking in our front door with. So as you can see here in a Massachusetts study, 92% of women surveyed who were experiencing homelessness had experienced severe physical and or sexual assault at some point in their lives. And 60% of those women had experienced it by the age of 12. That is a really significant statistic. And other studies have shown that many women experiencing homelessness suffer from emotional symptoms like major depression, substance abuse, and PTSD, as you can see here. So just so you don't think these statistics are conflicting, on a previous slide we showed that a very small or minority percentage of folks had substance abuse and mental health issues. Those were specific to chronic substance abuse and serious mental illness. So people experiencing homelessness often do have mental health or substance abuse issues, but they're not as serious as sometimes we see the stereotypes. So even though these statistics are just focused on women, men experiencing homelessness have very significant trauma histories as well, and children. So it's not just women. So the first thing we need to do in a trauma-informed approach is just assume that everyone walking through the front door has experienced significant trauma. And the other thing we can assume that they're experiencing homelessness is that they are currently experiencing a traumatic event. And trauma plays a big role in the way our brains think, how we respond, and how we make decisions. So often we can have kind of negative thoughts when we see different behaviors coming out of clients. But if you think about the fact that they are currently experiencing a traumatic episode, then we can understand that they're responses to treatment, the decisions that they make that sometimes we think aren't the best solution, are actually coming from their brain and the way they're processing the trauma. So a trauma-informed approach reflects a fundamental shift in the culture of an entire organization. So if we're going to call ourselves a trauma-informed organization, these are the four things or the four R's that we need to know. So we need to not only realize how widespread the impact of trauma is, but more importantly, we need to understand the potential paths for recovery. So this means, I believe, everyone can recover no matter how significant the trauma. So even though we see these really astounding statistics of trauma, which can, make us feel a little hopeless and helpless as providers, there are paths to recovery. And we've seen this. People with significant trauma histories have recovered. So we can rely on that and to be hopeful about their recovery. Second, our organization should recognize the signs and symptoms of trauma in clients, in their families, even in staff and others involved with the system. So as a professional, we are seeing the trauma in our clients, but we are also learning to recognize trauma in our coworkers and other staff. And this helps us grow and understand when we are experiencing trauma ourselves. So some professionals have called this vicarious trauma or secondhand trauma, but really it's just trauma, like any other trauma. And as a behavioral health professional, you are experiencing trauma. When you listen to these stories, especially if you're working in crisis stabilization or detox, you are dealing firsthand with people experiencing significant trauma. And so we need to understand the impact it's having on us so that we can better serve our individuals. Third, the organization responds by fully integrating knowledge about trauma into policies, procedures, and practices. So one way, an example I can give you of this is in the mental health system, there is a big push right now to find alternatives to seclusion and restraint in our treatment. And that's because we know seclusion and restraint can actually have really damaging long-term consequences. So for instance, usually in a seclusion and restraint, there's a physical aspect of that, so people can get physically hurt from that. Some people have even died from injuries sustained during a seclusion and restraint. So a trauma-informed approach would get a little more innovative and say, okay, before we escalate it up to a seclusion and restraint, what can we do to try to respond to this incident and still keep everyone safe, including staff? And it's also an example that sometimes the measures we are using to make ourselves feel safer, or we think we're making the client safer, actually ends up escalating situations and re-traumatizing individuals. So there are obvious situations in which you would have to use exclusion and restraint, but often we jump to these really extreme measures that end up doing more harm than good. And this leads us to our final R here, which is resisting re-traumatization. And we do this in kind of little ways that we don't always think about. And so an example of this would be, think about the ways people are re-traumatized when they're arrested, or every time they are Baker acted or treated less than by professional staff. These are all examples of re-traumatization, and sometimes they're intentional, but most often it's unintentional. We don't really show up at work every day thinking, oh, I'm going to re-traumatize my client, right? So some of these things we can control, like trying to make our spaces and facilities brighter, spacious, and peaceful, but some of them we can't. So not arresting someone is not always an option. Sometimes we are on the receiving end of someone being Baker acted, and there's not much we can do about it at that point. But we can be more understanding and keep these R's in mind. So trauma-informed approaches can be implemented anywhere by anyone, and everyone in the organization, from the front desk up to the CEO, has a role to play in becoming trauma-informed. So I want to review now SAMHSA's 6 principles of trauma-informed care. Number 1, safety. Do clients feel safe with us? Not only physical safety, but emotional safety. Do we as staff feel safe in our places of work? So again, safety is really key, not only for clients, but also for us. And so these are some of the questions and the things we can start looking at with our policies and procedures. Second, trustworthiness and transparency. This means that our organizational operations and decisions are conducted with transparency and the goal of building and maintaining trust among clients, staff, and others involved with the organization. So think about this for a minute. As staff, do you really understand how operational decisions are made? Or do you just get an email saying this new policy is in effect starting Friday? So often it happens at the latter, especially if we're in a big organization. So to follow this trauma-informed principle, an example of that might be that there are a group of stakeholders, including people experiencing homelessness or including people with behavioral health issues, that are able to help in making those decisions. And we're giving plenty of notice ahead of time when a policy is going to be changed, not only to staff, but we're also communicating that to our clients in every way we can to make sure that we're being transparent, not only about the policy, but maybe what is the why for the policy. Third, we have peer support and mutual self-help. So these really are the key vehicles for some of our clients for being able to establish that safety and hope, for building trust, and for enhancing collaboration. So peer support should serve as a model of recovery and healing, and it really can maximize our clients the way we empower them. So peer support is a great asset to any organization, especially in our mental health and substance abuse facilities, because it just offers an example, the model that, hey, recovery is possible. 4, we see collaboration and mutuality. And this is really finding ways to partner and level power differences between staff and clients, but also from organizational staff all the way down to direct care workers. So this is important. This means that when our clients are coming to us, often we're seen as kind of the authority or the person that really holds a lot of the weight of how this person's case is going to go, what resources they're going to have access to. And we need to keep that in mind when we're meeting with clients. And we need to try to find ways to level those power differences. One example of this is, again, having a consumer maybe on the board of directors. And so it's not just people on the outside or people in higher levels and positions that are making all the decisions. So this principle really demonstrates that healing happens in relationships and in the meaningful sharing of power in decision-making. So we can have a big impact on empowering our clients. And here in this principle, I think it's really important that we be authentic. So clients really know when we're being authentic. And you probably have even experienced that. When you're talking with someone, you kind of get that vibe. Is this person being real with me? Are they being genuine? And our clients and consumers pick up on that for sure. So being trauma-informed says that, okay, I recognize that there is a level of empathy I need to be able to provide here. And just because you might not have experienced homelessness or you may not have a mental illness, anyone can express empathy. If you've experienced any kind of trauma or painful event in your life, then you have that empathy. So empathy is not sharing all the gory details of your trauma with clients, but empathy is getting in touch with that thing inside of you that has experienced pain, and being authentic with your clients, being able to say, I understand, and I'm here for you. And that must be really painful. So acknowledging that sometimes they're going through really difficult situations and that we are looking at them as a unique individual with their own story, and we're being authentically concerned about what's going on with them. Moving on, number 5 here, we have empowerment, voice, and choice. So this means that we are recognizing individual strengths and experience, and we build upon that when we help them. We encourage choice. So often there's not a lot of choice in some of the settings that we work in. So if you work in substance abuse, there's probably an inpatient treatment. It's not allowed that you can use during that, right? That's not a choice. But what are some other ways we can provide choice in that environment? So we're always looking for ways to provide that choice. It's encouraged because we know that when we provide choice and we try to develop those self-empowerment skills, we're actually fostering a belief in resilience. So I just want to say this too, that our belief in our client's ability to recover has a direct impact on them. So if we believe they can recover, they are actually, that's increasing their chance and likelihood that they will recover. And likewise, if we don't believe that our client can recover, we think, oh man, this person's been cycling in and out of the system for years, they're never going to get clean and sober, they're never going to comply with treatment. When we believe things like that, we're actually decreasing the chance that they will recover. So we really need to keep that in mind when we're working with people that we would consider difficult or the most vulnerable people, the high utilizers. We have to remain open and believe that they can recover. And there's a documentary I really like called Healing Means, and you may have seen it. It highlights a woman's journey, Toni Arcane. And one of the things she says towards the end is she talks about when emergency services like EMT or ambulance come up to an event or a call, even if that person has the faintest pulse, they still get to working on them. So they're still doing CPR. They're still doing everything they can to save that life. And so she says from that, her quote is, where there's breath, there's hope. And I absolutely love that statement because it's so true. Sometimes, you know, as providers, we see people in and out. We kind of get jaded or, you know, we get used to someone being a certain way. And we have to kind of look at ourselves and say, okay, am I believing that this person has the potential to recover? All right, so let's move on. The last principle here, cultural, historical, and gender issues. So this principle is when the organization actively moves past cultural stereotypes and biases, because we all have them, and sometimes they're organization-wide, and we start to offer gender-responsive services. Again, we understand the healing value of cultural connections, and we try to recognize and address historical trauma. So I think this is a big one. We are working in systems of care which have historically, in some situations, treated people poorly, people of different cultures. We haven't respected what they would like to see their recovery look like. We have had some oppression, you know, things like that. We need to recognize this historical trauma that our system has been a part of and look at our policies and say, okay, when was this policy created and is this still appropriate to the client and the end user? So one thing you'll notice about these 4 must-haves, being trauma-informed, recovery-oriented, strengths-based, and client-centered, is that there is a lot of crossover between these approaches, and they are meant to be used together and intertwined. So next, we're going to talk about being recovery-oriented. All right, this picture here, I think, is a great reflection of the reality of recovery. So sometimes, or a lot of times, our programs are designed and our expectations are that recovery look like the arrow on the left. Sometimes even our clients' expectations of their recovery looks like the arrow on the left. But the reality is the arrow on the right. And you know this. And when I'm talking about recovery here, I am not just talking about addiction. I'm talking about substance use, co-occurring disorders, trauma recovery, PTSD. I mean, there are a lot of things our clients have experienced that all play in to their journey of recovery. So I just want us to keep an open mind when we talk about recovery and realize people can recover from a lot of different things, and often there's some crossover there. All right, so let's look at some of the values of a recovery-oriented approach. All right, number 1, we respect the individual as an expert on their own life. So this means we expect they are not always going to make the decisions we think are best or the quote-unquote right ones. So we allow them the space to make decisions we disagree with, and we recognize that they may feel that is the best choice for them. So one example I relate to with this value is think about when you go to a doctor's appointment. There have been times I've gone to the doctor and they are just not listening to me at all. They just jump right in to telling me, you know, here's your diagnosis, here's the medicine, here's what you need to do to get better. And then I don't feel like they're hearing me at all, right? They're getting me in and out of there in 5 minutes. And even though that doctor has a medical degree, I know my body better than anyone. I know my symptoms. I know how I feel better than the professional in front of me. So if I disagree with the doctor, a good doctor, I think, should respect me enough to listen, at least give me the courtesy and the respect to listen to what I'm saying. So it's fine if they disagree. It's fine if we disagree with our clients. We can still educate and inform them. If you make this decision, then this might happen. This could be the consequence to that if you make this decision. But we're still saying they're the ultimate authority when it comes to their treatment, and we respect their decision, even if their decision is not the one we think they should make. So we're giving people all their options or what choices that they have. We're not using terminology like you should make this decision or you have to do this or else. We're not giving people ultimatums in treatment. We are respecting their decisions. And this, you know, is really important because I believe in some of our work we just, you know, take for granted that people should make certain decisions on their life. So we're going to talk coming up about being strengths-based and person-centered. So I'm not going to dive into those too much, but I want to talk about recognizing that recovery looks different for everyone. This is a big value here that we need to have. So just because we're treating clients that have similar symptoms or similar diagnoses, this does not mean that they are going to, nor should go, down the same recovery path. So let's talk about substance use. Some people choose total abstinence, and others want to continue to use to some extent. And we need to be able to respect that. There's even other people who will do well with medication-assisted treatment, like methadone or Vivitrol. So if you've been in the field of substance abuse for any length of time, I will just go ahead and guarantee you, you've already come across clients and staff with strong opinions about medication-assisted treatment. So this is a good example, I think, of where our personal beliefs can get in the way of a recovery orientation. So years ago, when I had some clients receiving methadone treatment and getting, going every day for their dose, I really personally had an issue with it. In my mind, I thought, you know what, this is just another way to use and keep someone addicted. And my personal belief, even though I did not voice it to those clients, probably came across in some way in my interactions with them. And that's why we have to be really careful and understand and be able to be honest with, what are my personal beliefs about this? But as time went on, I began to understand with my clients that had serious addictions, heroin use, opiate use, alcohol use, that they did not want to get sober. That was not the end game for them. The end result that they wanted was to be able to have more control and more control over their life, so that the effects of the drugs weren't interfering with things like work and, didn't want to get rearrested, things like that. So we have to be open to that. What is the research saying? Okay, so putting my personal values aside and say, what is the research showing? And what we see now is that recovery looks different for everyone. So historically, we have said, this is how you get clean and sober. This is how you access mental health treatment. These are your options for medication. And, you go to inpatient treatment for 30 days, and you get out, you need to do a step-down halfway house, you need to do 90 meetings in 90 days. I mean, a really strict formula. And for some people, that works. But if you work in substance abuse, you understand a high rate of the people that come out of inpatient treatment relapse and use again. So we need to come up with better effective interventions. We need to look at what are we doing and then what does the data say? Is there a better way to get my client on the road to recovery? And my answer to that would be yes. And one of the ways we do that is by asking them, what do you think your path to recovery looks like? So one method that can be very effective is harm reduction. And we'll talk later about housing interventions, because really, as we mentioned before, that's the first step. If your client that you're working with doesn't have stable housing, it's going to be difficult to have success in things like adherence to mental health treatment and recovery from substance abuse and trauma, because, again, they're in the middle of experiencing a traumatic event. So we'll talk later about those. And actually, Housing First is a great example of harm reduction. But I want to address some of the confusion and misconceptions about harm reduction, because some people are really against this. That's just the fact of the matter. I've heard this in the places that I've worked for sure, that, this is just a way to keep people from taking personal responsibility, that they can continue to make bad choices with using and things like this. So let's look at what harm reduction really is. We took this information from the Harm Reduction Coalition, and there's a link at the bottom if you want to look up more of what they have to say. But here's a list of what it is and what it is not. So harm reduction does not minimize or ignore the real and tragic harm and danger associated with behavioral health disorders. So we understand that some people have very high-risk behavior, and that can be very damaging with them, for them. It accepts, for better or worse, that drug use and untreated mental health disorders are part of our world and the lives of those with whom we work. So remember that slide on recovery showing our expectations? We need to shift over to the reality portion and have some acceptance here that people are going to use drugs. And I remember working with somebody one time. It was a very high-risk child welfare case, and there was a history of substance abuse on one of the parents' part. And in an assessment, they found out that the mother was using drugs. And they just, you know, we were sitting in a staffing, and they were just going on and on about it, like how they were so shocked and they couldn't believe it, and this person might lose their children. And I sat there and I was thinking to myself, well, yeah, I mean, I would expect that there's probably some level of drug use going on given what's going on in the home. And so the sooner we can accept the reality of that and not be so shocked at the things that our clients are doing, because clients are clients for a reason. They are struggling with different issues and they're coming to us to get help with that. So the sooner we can accept it, the sooner we can work with that client on what their goals are and what they think their recovery looks like. The other thing harm reduction does is it works to minimize the harmful effects rather than ignore, condemn, or demand treatment or sobriety at all times. So again, this is a more flexible intervention tailored to the needs, trying to minimize those harmful effects that we know are there when people use or don't take, you know, their medication or things like that. So it recognizes that some ways of using drugs are clearly safer than others. That is just the truth, right? So we know that smoking a certain drug may be less harmful than shooting up the drug. And so we need to be well-versed and understand what are some of the safer ways to use drugs. And some approaches to living with mental health disorders are clearly safer than others. So being open to creating a crisis plan with a client with a mental health disorder. We may need to say, what does it look for you to be safe or safer than how you're currently living? And finally, it affirms consumers themselves as the primary agents of reducing the harms related to behavior. So again, seeing people from a recovery-oriented approach that they are the expert. So one example I can think of this is planning with someone to reduce their drinking or to only drink or use at certain times of the day or in certain places. So I had a client, this was in a permanent supportive housing program, who used crack, and it was very difficult. He had gone to treatment several times. He always usually left or either relapsed immediately after treatment. And so this was, to me, a really difficult case. And so I had to think outside the box here. And because, you know, the main goal of our program was to remain stably housed, I did not want that to be in jeopardy. So what we agreed to was that he would never use in his apartment or at the apartment complex. Like, no one should know where you live that you use with, right, because that would be harmful to him. He, you know, lived in a neighborhood where he had nosy neighbors. It was not the greatest part of town, and the people living in that complex wanted to keep crime out. They wanted to keep drugs out. So if there was any suspicious behavior, they were calling the police. So the 3 years that I worked with him, he remained stably housed. He also never was in jeopardy with his lease or property manager, and he always used off property. So this was a less harmful way of using, even though I clearly recognized that using crack was very harmful for him. And we definitely talked about that, but this was like the first step with him so I could keep him stably housed. So I don't want to go into too much detail here and say, you know, this is how you do harm reduction, because it really needs to be tailored to the needs of the individual. But this is a great method in conversation to have with your clients, especially if you're working with people who don't want to take mental health medication or are not going to remain sober and clean. They just don't want to. So I do want to put this disclaimer on here so that you're not running out today and trying to do harm reduction. If someone has very significant use, right, if they have a serious mental illness or they are, using very serious drugs or very heavy drug use, this needs to be a discussion with their healthcare provider or substance use professional. So, it's not really, it's up to you if you're a case manager to say, well, you're drinking this much, we need to reduce it to here. So that could have some very, harmful physical ramifications. So harm reduction takes the judgment out of drug use, and period. That's what it does. We are accepting there's drug use in our world, and we are trying not to judge that or condemn our clients, right? They probably already acknowledge and have been told 100 times, not 1,000 times, that what they're doing is harming their bodies, harming their family. Look at all these devastating effects. Don't you want to be able to reconnect with your family? There's so much, judgment and things that we do that actually harms people more. And so we're going to take our personal judgment out of it, and we're going to try to help the person reduce as much harm to themselves as possible. And so in mental health, I talked earlier, this might be a crisis plan. So a crisis plan recognizes that there will be a point in time when the client might be in distress, and the crisis plan is going to help reduce that harm. It's going to say something like, you're going to call me when you're feeling this way, or you're going to get rid of, the knife you have in your nightstand. You're going to do these, 3 things before you cut yourself. So we just need to get real and accept these things happen, and our clients participate in behaviors that we may not agree with and that we may think are really damaging to them, but we're going to come up with a plan for them based on what they're telling us and what their goals are. So if we set the bar so high, like you're just going to have to remain sober, forever, that's a really tall order, right? Even in AA, NA, or any other 12-step program, you take it one day at a time, or even, 1 minute at a time sometimes. So we need to realize that recovery is this journey. It looks different for everyone, and we need to be able to embrace that. All right, so we are almost here at the 1 hour mark. So I think we are going to go ahead and take a break until 12:35.
Yes, hi, this is Leanne. Thanks very much. We can take our break now and come back at 12:35. And Amanda and Susan, I wanted you both to know that I sent a private message to you each in your chat panel just for a couple of points of clarification that have been requested. So you may just look at that at your convenience and perhaps loop back to it a little bit later.
All right, great. I will do that right after the break.
Okay, thank you. Welcome back, everyone. Amanda or Susan, are we ready to proceed?
Absolutely. All right, so next we're going to talk about a strengths-based approach, and I just want to say we are going to look at the questions in a few minutes. So I do see some of you have asked some questions. The other thing I want to mention is that in the chat box, I put the information for that documentary that I mentioned earlier because the name, I know in the title, it's kind of hard to say. So check out the chat box if you're interested in what that documentary was about Tony or Kane. All right, so let's talk about using a strengths-based approach. All right, so a strengths-based approach really just means that we are not only focused on identifying barriers. So we're asking, what strengths does the consumer have? A lot of times our assessments are deficit-based, and we're just collecting all the information about what's wrong with them, you know, all their barriers and negatives. So we need to look at strengths. Do they have any family support? Do they have any social support coming in by any means? Are there any income sources? Are they keeping appointments? So when a consumer is sitting in front of you, that is often a choice they have made to seek help, not always, but we can start from there. So often we have a hard time finding strengths, especially with people who are cycling in and out, and it seems they don't have any social support, family support, or anything. But I like to think, okay, if they're sitting in front of me, this is an opportunity. This is a strength. They're sitting here talking to me. And lastly, we need to think consumers are often very resilient, and our job is to continually remind them of that resilience. So earlier we talked about trauma. Think about all the trauma consumers have been through, and yet they're still seeking treatment. They're still sitting in front of you. They have not killed themselves. They have not overdosed. So we need to remind people that they are very resilient. They have already overcome huge obstacles. And there is no failing, okay? So I really think a big part of a strengths-based approach is getting rid of this non-compliant language that we have. Consumers are going to have ups and downs in treatment. This is expected. So you can go ahead and plan for that. Something is going to go wrong, right? So we need to remember that consumers are here for a reason. They have something going on, and they need help with it. So I think it's easy to lose sight of this, just coming from a personal perspective and working with people one-on-one. Sometimes we have unrealistic expectations of consumers. So this does not mean we have no expectations and, you know, we think it's doomed from the beginning. No, we believe in their recovery. We foster that spirit of resilience, but we also understand life is not perfect. Also, one thing that's a little backwards from the way our system works is when consumers begin to pull away, we actually at this point are going to step up and increase our engagement with them. So we're going to call. We're going to check in with people. How are things going? Is there anything I can do to help you? Instead of just saying, oh, that person's non-compliant. The next thing is we do not exit consumers too quickly. So we're not letting people drop out of care easily. So in fact, the more a person is struggling, the more intense services need to be. This is a big shift from the way we typically do services. So a lot of times we have a very strict policy on, you know, if I haven't heard from this person in 30 days, then I'm going to staff their case for closure, you know, things like this. So don't wait for the consumer to call you, okay? Actively engage consumers and don't exit them too quickly, especially when we have difficult cases. So I'll be honest, it can be easy to feel relieved when someone who is highly difficult to work with suddenly disappears, okay? But trust me, that person is most likely going to pop up again at some point. So again, if we're just closing people out, it just makes it that much harder for the person to engage back in services when they're ready. So you may have to close them out, like I was in a program where, you know, we had that strict policy. I think it was, you know, after 90 days of no contact, the person's case was closed. But one of the things that we did was that person could come back at any time and receive services. They would be opened right back up. So it wasn't, you know, this long wait of, well, you've got to wait 6 months because, you know, you dropped out of care and you did this and that. No, we did everything we could to try to reach out and keep them in care. And this can be hard, especially when we have a lot of clients. When we have huge caseloads, you know, it's easy to think, well, if they want services, they should keep their appointment or they should call me. But really, when someone is pulling away, we need to understand something's going on there. There's a reason why they're falling out of care. And what is it? Is it me? Do they not like me as the worker? Is it the clinician they're seeing? Is it the psychiatrist? You know, things like this. So being able to have those honest conversations, you know, I noticed you haven't been in a couple weeks or you missed your appointment. You know, what's going on? So if they miss an appointment, are we calling them to check in and see, you know, hey, what's going on? The other thing here is that staffing should be used as times to discuss solutions. And I put this in here because too often I've seen and heard and been a part of staffings that are so focused on all the negatives. It's almost like this telling of a dramatic story. For example, you might hear, you won't believe what so-and-so did this week, and then fill in the blank. This is not effective. It's not based on strengths, and it is essentially just gossip about the consumer. So think about if that consumer was standing in the hallway overhearing your staffing, which they shouldn't be because that would be a HIPAA violation, what would I want them to hear? Would I want them to hear what I really am saying about them? Again, this leads back to that trauma-informed principle of being transparent. I'm being honest with my clients, and I'm also using staffing as a place where I can get feedback from my colleagues to get help. What other strategies, you know, might work for this person? What resources am I not aware of that might help this person? So staffings, again, you may be addressing barriers, but you're also addressing strengths. So on your staffing form, if you have one, there should be both of those columns. There should be a barriers and there should be a strengths column. And then at the end, there, you know, the bottom really should be who gave me what input and what are the solutions going forward, not just challenges. And then again, as I mentioned on the prior slide, difficult times are actually a sign maybe that a higher level of services may be needed. So I want to clarify something here. When I say a higher level of services, I'm not talking about a higher level of care in the sense, you know, that maybe we need to move someone into an ALF or nursing home or something like that. I'm not talking about that because in mental health, it's our job and we are tasked with keeping people in the least restrictive housing options. So when I say a higher level of services, I'm talking about the resources we're providing. I'm talking about how often we are engaging that consumer, all right? So for example, you might need to move someone or staff them to move from outpatient case management to intensive case management. You could also think, hey, is this person, could they use assertive community treatment? How do I get them involved in that? Are they eligible for forensic case management? So we're always looking for those resources if we have someone who has a lot of difficulties and needs more services. And finally, we cannot predict who will succeed and who will fail. We can't, no matter how picture perfect a client looks on paper, or no matter how many barriers someone has, we do not know when people get into treatment, right, who's going to be successful. You don't know. In substance abuse inpatient treatment, you don't know who's going to leave that facility and stay sober or stay clean, or who's going to relapse. So our job then is to provide everyone with the same opportunities and the same choices tailored to their needs, not just compliant consumers. So we're not playing favorites here and saying, well, because I really like this client, I think they're better suited for this housing option than this person. The person with more barriers actually might be the more appropriate person to put into that housing, because stable housing is going to make all the difference in their recovery. So we're prioritizing people for opportunities according to the greatest need, not just the clients that, are doing better or that we like. All right, so let's look at an example here. Let's call this woman Mary. So if we're focused on barriers, we're going to say Mary is considered a high utilizer because she has over 15 inpatient psychiatric admissions in 6 months. That's a pretty high number. She's cycling through the system, jail, hospital, crisis stabilization, detox, and in complete denial of substance abuse. Refusing housing options that have been recommended. So she's actually been offered some housing here and she's not interested. She's also continuing to miss appointments and doesn't really seem interested in receiving treatment. All right, so let's change this. Let's focus on strengths of Mary instead of just barriers. Well, she's engaging with the mental health system on some level, even if it's one appointment every 6 months, or even if it's her willingness to talk to someone when she's at the CSU. She's been receptive to the outreach worker that has been coming and trying to engage her. She actually might have some SOAR potential here with getting SSI or SSDI. And if you don't know what SOAR is, it stands for SSI, SSDI, Outreach, Access, and Recovery. And you may have a SOAR navigator in your area, and this is specifically for people experiencing homelessness with a mental health diagnosis to be able to access benefits. Maybe she has fewer admissions when housing was stable in the past. She has been responding well to peer support. So again, if you have these, like this is a staffing form, you may have these 2 boxes on here because we do need to know what the barriers are, but we also need to identify some strengths with Mary. Okay, so let's talk about being client-centered. And this is interchangeable, client-centered or person-centered, just FYI. So first off, our assessments are going to be based on the consumer strengths, goals, risks, and protective factors. The assessment needs to be able to look at the person uniquely and not just getting to the same result with all of our clients. The tools and assessments need to be understood. So when someone's coming to us, are we explaining? First, we're going to do your intake and assessment. This is when you're actually going to get an appointment to see the doctor. We're informing them of what the program looks like. And we need to be sensitive to our consumers' lived experience. Sometimes, people are required to just rattle off all this personal information over and over and over again, right? Even a form of re-traumatization sometimes. So we need to be sensitive and appreciative when a client is sharing information with us that is sensitive, that is personal, that could be traumatizing. saying thank you, but also looking at our assessment forms and saying, is this really necessary to collect all this information? Or, given the services we're going to provide, should we be asking less? We're also going to offer choice to the extent possible in decisions about housing programs, treatment options, etc. And consumers need to be able to understand which program they are being referred to. So again, being transparent and letting them know, these are what your options are. So a case management or case manager role is not fixing people. People are not broken. We're not using coercion for people to accept treatment. We're not dismissing or minimizing the importance of their goals. We're not using a parenting style or, that we know best for them. What a case manager or clinician's role is respecting choices even when we think differently, providing a safety net if or when there is relapse or slips, being transparent about options, choices, what you're able to provide, encouraging autonomy, and lastly, facilitating recovery. So, we sometimes need to really rethink the way we are providing services. And I'm going to go ahead and turn it back over to Susan to talk about what the housing crisis response system looks like.
Thank you, Amanda. I think it may be time, let's check with Leanne to see if we'd like to do questions and answers now at this point.
Of course,
Leanne?
That's fine. Did you want to, Susan?
Yes, let me just begin by responding to a couple of questions and topics that have come up. The first I'd like to, there was a really good question kind of early on, and I really appreciate this question. And it related to that slide where we were talking about the misconceptions of homelessness. And the question was, but why are you calling them misconceptions when, in fact, substance use and poverty and mental health issues all contribute to homelessness? So let me just add that that's a really good question, because what we do know is that the presence or incidence of behavioral health problems, that is overrepresented in the homeless population. So there is a higher percentage of people who are homeless that have those issues compared to the general population of housed folks who have those issues. So it is absolutely true, as that questioner was implying, that folks with behavioral health issues are more likely to be homeless than folks without behavioral health issues. So that's absolutely true, and as Amanda has described, and she's just had so much experience, and the reflection on working with folks who are homeless with behavioral health issues is just incredible. As she has pointed out, we can't and we shouldn't ignore the presence of behavioral health issues among those who are homeless. That is a factual data point. I think that the point that we were trying to make about misconceptions is that folks tend to paint kind of with a broad brush. Anyone who's homeless must be homeless because they have a substance use or mental health issue. And I think it's that because that's problematic. Yes, there are some folks who are homeless that have those issues, but there are a lot of folks who are housed that have those issues, and there are a lot of folks who are homeless that don't have those issues. So that kind of, because of this behavioral health issue, there is homelessness. I think that that's what we need to break free of. So what we, some other data that we have indicates that people who become homeless for any number of reasons, and even if they have a mental health or substance use disorder, that might not have been a contributing factor to their becoming homeless. So they could be rehoused and assisted in maintaining stable housing even with those problems. And I think that's kind of a major take-home from that because, especially in the behavioral health field, we tend to kind of look through the prism of mental health and substance use, that there's almost an assumption on our part that has to be addressed in order to fix this housing crisis. But in fact, what we know is that first you fix the housing crisis, and then you make those services available for folks to remain stably housed and enter into recovery. But that the equality, the idea that one thing leads to another, therefore must be fixed before housing is possible, I think that's the equality we're trying to break open from. So I hope that's helpful, but I do want to affirm that it is true that many people who are homeless have behavioral health problems, and once housed, they need access to services so that that doesn't become problematic in the future. I'd also like to mention that the longer a person is homeless, the more likely their behavioral health problem will be exacerbated. And so rapidly rehousing someone is the best way to prevent that from happening. So a person who's been chronically homeless for 10 years and living in encampments is probably drinking more now than when he first became homeless, because that's what happens. And so rapidly helping people get out of homelessness will help that problem from becoming even worse. So I hope that was helpful.
Thank you, Susan. Amanda, I've got a question for you regarding the name of that documentary. Did you say that you attempted to post the name of it in the chat panel?
Yes, I did try to send it out. I don't know if it worked or not.
If you will just send it to me, I will distribute it to everyone who had a question about it. And that's all we've got right now. We've got another question that we may want to loop back to as time permits toward the end of the session. But I think we're ready to proceed when you are.
Okay, super. Thank you, Leanne. And I'd like to, before we jump into the housing crisis response system and those components, I'd like to also add a little PS onto some of the issues that Amanda was discussing. When we're working with folks who are experiencing homelessness, sometimes the expectation that people will make appointments or respond to phone calls isn't as reasonable with people as it is with people who are housed. So to the extent possible, having alternative ways of reaching folks rather than expecting them to come into the office or to respond to a phone call is really helpful. And I'm going to touch on that as we go through these next few slides as to how we might think about doing that. So now we're going to look at the housing crisis response system that occurs in communities. First of all, a really important concept to understand is the idea of the homeless continuum of care. The continuum of care in the homelessness world is often called the COC. So the homeless COC is a group of people whose job it is to plan to prevent and end homelessness, so to create the plan, to fund housing programs and services that are with the purpose of preventing and ending homelessness, and also to coordinate local collaborative applicants. So to be that lead agency, to be that leader, the convener of the many providers and stakeholders in the effort to prevent and end homelessness. So every community in Florida, with just a couple of minor exceptions, has a homeless continuum of care whose job it is to do this. And the continuum of care is a federal requirement administered by HUD. The COCs have the ability to decide kind of which geographic region they're going to cover. And so in some communities, there is a single county COC, and in others, there's a COC that covers multiple counties. There's also a lead agency identified by the broader continuum of care. So the continuum of care is kind of a big group of people all working to prevent and end homelessness, but then there's a COC lead agency that's tasked with doing the plan and implementing and doing the coordinating. And they also apply for and receive federal funds from HUD to help with that effort. So these COC lead agencies are groups that, if you're not already tied in with them, it's really a great starting place if you're working with folks who are homeless. So here's a map of the state of Florida with all of the continuums of care listed here. And there you'll see the picture shows that, for instance, Miami-Dade is a one-county COC, as is Brevard, as is Broward and Palm Beach. The Big Bend, on the other hand, has many counties. So wherever you are on this map, you can contact your COC lead agency to get involved in that system. If you want to find out who the contact person is, you can click on this link that we provided on this map where it says DCF Homeless Leads. So DCF has an Office on Homelessness, which is located within the Office of Substance Abuse and Mental Health in DCF. And so there is a really close relationship administratively at DCF between SAMH and the Office on Homelessness. And the Office on Homelessness is the group that works most closely with the COC lead agency. Another thing to note is that I'm sure many of you are familiar with the managing entities that are serving Florida. So there are 7 substance abuse mental health managing entities in the state of Florida. Compare that to the 27 COCs in Florida. So a single COC might be working with multiple managing entities, and a managing entity might be working with multiple COCs. So things are not clean and simple here. So you may have a managing entity, a relationship or funding from a managing entity with SAMH funding from DCF, and the COC also has funding from the Department of Children and Families Office on Homelessness. So you have that in common, but there isn't a one-to-one correspondence between managing entities and COCs. But a really important thing to note is that every managing entity is required by DCF to work on housing care coordination. That is a mandate from DCF. And so the managing entities are tasked with working with the COCs and vice versa to work on housing care coordination for consumers in the behavioral health world who are experiencing homelessness. Each managing entity has at least one housing coordinator whose job it is to assist with housing coordination for consumers who are homeless. And those managing entities sometimes, but not always, have a seat on the Continuum of Care board, may be very closely collaborating with the COC. And so the overlap, the collaboration is really crucial here between the MEs and the COCs and all of the providers, whether you're a behavioral health provider, a homeless services provider, a housing provider. The more collaboration, the better we can serve our consumers. This graphic here is a picture of the components that should ideally exist in every homeless assistance system or housing crisis response system. And I'd like to point out that although this is in a circle, I don't want to give the impression that it's kind of a 1, 2, 3, 4, 5 kind of progression. So for instance, with each of these components, this is an important piece of helping someone either not become homeless or to get out of homelessness as quickly as possible. And I'm going to touch on several of them very briefly and then speak to specifically the housing interventions that are shown on this graphic. So outreach and coordinated entry, I'm going to explain in more detail coordinated entry. But I'd like to touch on outreach briefly. PATH programs have outreach workers, and homeless assistance programs also have outreach workers. So almost every Veterans Supportive Services for Veteran Families program that works with homeless veterans has an outreach worker. Some COC lead agencies have outreach workers. Some housing providers have outreach workers. So this is one of those areas where if you are a case manager working in a behavioral health provider organization and kind of your general way of doing business is that people come into your office for appointments, then if you're working with someone who's homeless and you've called them, maybe they don't have any more minutes left on their phone. If they haven't come into the office, then maybe their encampment had to be moved, or maybe they're in the hospital, or maybe their substance use is so heavy that they forgot the appointment, or maybe they don't have a calendar. So that's where you collaborate with that outreach worker, whether it's a PATH worker or the homeless outreach worker or some other outreach worker, to go find that consumer so that you can reconnect with them and redouble those services, as Amanda mentioned earlier. Prevention and diversion is also important. Diversion is somewhat different from prevention. Prevention means somebody's in a house and maybe they have an eviction notice, so someone's trying to help them stay in the house. Diversion is different. Diversion is when somebody is like calling into the emergency shelter or the homeless hotline or showing up somewhere and saying, I'm homeless, I need a place to stay. Diversion is the process of helping that person find an alternative to entering the homeless system. Maybe they can go stay with family or friends or a coworker, that sort of thing. Emergency shelter is present in most communities, but not all. And that's should be a temporary place to stay. It should have low barriers to entry, low admission requirements. That isn't true in every community, but that's the ideal. Should be a place to stay just long enough for the person to get connected with the appropriate housing intervention. Before I move on, I'd also like to mention that one of the challenges and opportunities that has been occurring in the homeless assistance system in the past few years is an attempt at right-sizing these various components. In other words, what we find in many communities is that there's perhaps zero emergency shelter, but a lot of transitional housing beds. Maybe there's a lot of emergency shelter, but no permanent supportive housing, which we'll turn to in a minute. So one of the things that the continuum of care is tasked with doing is creating a system that has the right resources for each of these components and at the right level. Alrighty, I'm going to move on and talk a little bit about coordinated entry, which probably many of you have heard about. Many of you may have actually accessed coordinated entry. This is a relatively new idea in the homeless assistance system. And let me just give a kind of a brief summary of how coordinated entry is to work. So let's say you have a consumer client who has just become homeless and you're trying to help them navigate the homeless assistance system. The way that should be happening in your community is through a process called coordinated entry. It's a consistent and streamlined process for accessing the resources available for people who are homeless. So here's a graphic. The folks at the bottom, they can look any number of different ways. Some are families, some are individuals, some have disabilities, some are behavioral health consumers. But they're all entering the homeless assistance system. And the coordinated entry system is intended to do a few things. Provide a common assessment of each and every one of those individuals or households, to quickly kind of triage folks in terms of what the needs are. And if you look at the top of this graphic, you'll see that folks coming into coordinated entry and being assessed should then be matched with the appropriate housing intervention. So some people may just need a very, what we call, light touch. Just point them in the right direction, help them a little bit, and they're off and running into stable housing again. Other folks need a little bit more help, and we call that rapid rehousing, which I'll turn to in a minute. And then other people, because of the severity of their needs and their barriers and their issues and their histories, need longer-term supports and housing assistance, and that's called permanent supportive housing. So the coordinated entry system is intended to match the consumer with the right housing intervention based on a common assessment tool. In many communities, but not all, that common assessment tool is the VI-SPDAT. It doesn't matter what that common assessment tool is. What should be happening is that every person entering the homeless assistance system is assessed and matched to the right housing intervention. So let's look at these housing interventions. Rapid rehousing is the first we'll look at. Rapid rehousing is a housing intervention designed to quickly help people get out of homelessness and into an apartment and offered without preconditions, without, for instance, a requirement of sobriety or income or marital, particular marital status. So rapid rehousing provides relatively short-term rent assistance and support services that are tailored to the needs of the household. Not a one-size-fits-all, but something that's tailored to that particular level of need. Oops, went too fast there. So for instance, one household might need a rent deposit, a utility deposit, and 1 month of rent to get into the housing, and then they're off and running. Another household might need a rent deposit, utility deposit, payment of past due utility bills, and 6 or 9 months of rent assistance so that they can address their housing stability issues, get employment, do all of those other things that they might need to do before they are able to sustain housing. So rapid rehousing should be individualized and tailored. We don't see that in some communities, but many communities are learning best practices around rapid rehousing to do a really tailored approach for those households that need a short-term or moderate-term level of rent assistance and support services. I would like to add that both for rapid rehousing and our next housing intervention, services should not be required, should not be mandated, and housing should not be dependent upon program compliance. So again, help folks get into housing, then provide voluntary access to support services that they might need. Permanent supportive housing is much longer term assistance, perhaps permanent. Perhaps for the rest of their lives, they will receive financial assistance and support services. This housing intervention should be limited or specifically for those folks who are chronically homeless, long-term homeless, have the most severe disabilities, might need assistance throughout their life to remain stably housed. Some may not be compliant with mental health treatment or medication or substance abuse treatment. The idea here is that you, kind of going back to what Amanda said, we have hope for every single individual we serve, and we're going to help them stay housed while they're dealing with recovery in their own way, and that could take some time. So intensive case management and assertive community treatment are very effective in ways to provide those support services to these individuals. And the managing entities should be flagging and prioritizing case managers' consumers if they fall into this kind of category: chronically homeless, long-term homeless, and serious disabilities. It's really important that folks who are the most vulnerable don't fall through the cracks. The most vulnerable folks, those whose lives are at risk if they stay in that encampment, they should be prioritized for permanent supportive housing because that's what they need, and that's what will work for them. So here's an example of one permanent supportive housing program in Florida. There are many of them, but this is just one on which we have really current data. This is a permanent supportive housing project that's run by Ability Housing, and there's a link at the bottom of this slide if you'd like to learn more. But the folks who are in this housing, and these are apartments, you know, just regular apartments. It's not a shelter. It's not transitional. These folks have leases, and they're living in apartments. And they identified the highest utilizers of emergency services, jails, hospitals, CSUs, and they specifically reached out to those individuals that were among the quote-unquote hardest to house, and they helped those folks move into these apartments. And they tracked the data for those households before and after housing, and this is 1 year of data, and they saw these huge reductions after housing in jail bookings and arrests, and costs associated with homeless services, hospital costs, and emergency room visits. So this solution, this permanent supportive housing solution, saves lives and saves money for the local community. Very, very critical component of the homeless assistance system, and may be appropriate for many of those with whom you are working currently, folks who are long-term homeless and have the most serious behavioral health issues. So at this point, I'm going to turn it back over to Amanda to wrap up a few final slides. And if we have time, we'll also do questions.
Great.
Amanda?
Thank you, Susan. Yep, I'm here. Okay, so we have a lot of resources to give you. So these will be available on the FATA resources in about 5 business days. So I'm not going to go through each link, but I wanted to put these up here so that if you are looking for more resources and help and information about these topics and housing interventions, I wanted to put these up here so you can read more about them. And especially with SAMHSA, they actually provide a whole toolkit on how to provide permanent supportive housing if that is something your agency is currently providing. So a couple of good kind of interventions and tools to have in your tool belt are motivational interviewing and progressive engagement. So I just wanted to mention those. I'm sure you've heard about them before, but these are some good links here to kind of help you learn more about those. All right, so one example that we wanted to highlight was Jacksonville, Florida, and their coordinated entry system that we talked about before. So how they do their coordinated entry is they actually contract with their mental health provider there to implement the coordinated entry. So they have a building there where they couple PATH, which is that Projects for Assistance in Transition from Homelessness. They couple those PATH outreach workers with coordinated entry and funding from the COC. So they have weekly meetings with homeless service providers, managing entities, behavioral health, substance abuse providers. They are all coming together to talk about those housing assessments that have been done at that location through coordinated entry. So the person is assessed, and then they are given a score by acuity. So the higher your score, the higher the acuity, and getting together every week to discuss these cases, because we know that people easily fall out of care, especially the most vulnerable. So they identify, you know, are they at a hospital? Who's working with them? How can we get this person housed? So I just thought this was a really good model in a way that mental health providers play a big role in the homeless service system. So you need to make sure that you at least have a representative from your agency showing up at these meetings if your community has them. The more people collaborating, the more successful your community is going to be. And I just thought I'd throw this quote up here. I really like it because often we tend to shift blame to our participants and consumers, But this kind of puts the onus back on us. If your services are meaningful to participants' goals, they will choose engagement. And that was from a rapid rehousing program in Portland. And I liked that because then it kind of puts the responsibility on us to make sure and ask ourselves, are we, you know, providing those meaningful goals and meaningful services? Okay. So again, here is another list of resources. The Florida Housing Coalition is our agency, and we provide several webinars and workshops and site visits, and we do that for free because we're contracted with the Department of Economic Opportunity. So you can look at our training calendar and register for trainings there. Obviously, the National Alliance to End Homelessness is a great resource to learn more about the statistics and the interventions, and then, of course, HUD, ORCODE, CSH, SAMHSA, and there are resources from the Office of Substance Abuse and Mental Health at DCF. They even have people that you can reach out to. So those are all the links, and again, in the PDF version, the links should be live for you to access. So now if we have any other questions, we have a few minutes to answer those.
Thank you, Amanda. Yes, we do have a few minutes left, and I do have a couple of questions. So I'll start with the first one, and it includes an acronym. I'm hoping you know what the acronym means. So it's like this. What do we do when the ME is unresponsive to requests for assistance with extreme cases?
Yes, I'll go ahead and answer that. I used to work for a managing entity, so I have a little bit of insight on that. The managing entity has someone that works for them. Each managing entity has it that is a care coordinator, and they oversee clinical care coordination and housing care coordination. So make sure that's the person you're reaching out to get that assistance. If you cannot get anyone at the managing entity to respond to you, then you would need to get in touch with the Office of Substance Abuse and Mental Health, because they are the funders of the managing entity, and there should be a regional coordinator there or someone in the office who can then respond to you, and they are very responsive. So that would be my advice there.
Thank you. And our last question came in right before our break, so it's been a little while. How does that example with your homeless client, harm reduction, work with the 12-step recovery system and the disease of recovery? I'm struggling with providing these options to a client.
Yes, I'll speak to that. So the 12 steps or 12-step programs are very effective with the people who choose to participate in them. But there are a large group of people who do not adhere to a 12-step program, nor do they want to attend one, because their goal right now, and I stress right now, may not be abstinence. It may be down the road. So one of the links that I provided before was motivational interviewing, and I would just recommend that you look at motivational interviewing to help you have those conversations, because the goal of motivational interviewing is to move people through the stages of change. And some people move through, some people it's very fluid, they go back and forth. So our goal is just to be open and provide and inform them of all their options, but then respect their choice also. I hope that answered that question.
Thank you very much. And if you're ready, Amanda and Susan, I'm going to take control of the presentation again and give some final comments.
Thank you, Leanne.
Okay, wonderful. All right, well, we're going to go ahead and wrap up the webinar for today. I want to tell, of course, Amanda and Susan thank you for joining us and sharing your expertise with us today. It was very informative, and we appreciate it very much. Also, I just want to say thank you to all of the participants who joined us. And as I mentioned at the beginning of the webinar today, do please watch for the opportunity to complete the evaluation, and that will allow us to send you a certificate of attendance and to report hours to CE Broker as appropriate. When you exit the event today, your browser will take you to that evaluation form immediately, but if not, if there's some difficulty with the computer, that's fine. You will be receiving a follow-up thank you email from us, and that thank you email will include another opportunity to complete that evaluation, so that should be fine. Do watch for your certificate of attendance and a PDF version of the presentation today that Amanda referenced. We'll be sending that out within 5 business days. And of course, as always, we archive these webinar events on the FADO Resource Center so they can be accessed at any time in the future by you or by any of your colleagues. And then finally, in closing, I want to be sure to thank the Florida Department of Children and Families, the Office of Substance Abuse and Mental Health, for funding today's program. So in closing, thank you to everyone and have a great rest of your day.